principle of disaster medicine management. It's a huge topic. We can't fulfill all topics in 1 or 2 or 3 or 4 even meetings. Please tell the next session. Search for Oxford Handbook of Disaster Medicine. This is the reference for us all. Oxford Handbook of Disaster Medicine Management. Today we will have a presentation for a principle, just the principles of disaster medicine management, and next week we will have a workshop for a triage. We will play, we will enjoy, we will calculate and interact with us ourselves. Today have principles of disaster medicine management. Disaster medicine management. What is the disaster medicine management? When we hear about this today, we will have a presentation of disaster medicine management. What's the concept of disaster medicine management? No single definition of disaster medicine management agreed with the expert till now. Every place or every hospital or every country have a different definition to deal with an event as a disaster. Disaster medicine management UN training program definition as a serious distribution of a society event, human or material or environment loss. The main topic we have agreed that this event exceeds the ability of affected society and it's on its own resources. That we have influenza at an example. We have the ability to deal hepatitis C, hepatitis B. We have the ability to deal, but when we faced COVID-19, the ability or capacity of the healthcare system that will be guide us that is a disaster or not. If we have not exceed the ability, it's not a disaster. When we have exceed the capacity or the ability of healthcare system, it's a disaster. What is the classification, the disaster definition? Recorded classification. We have a natural disaster, technological disaster. The severity of the disaster, we have the country, it's declared a type 1 disaster, type 2 disaster, type 3 disaster. Which is the disaster is internal or external disaster, compensated or non-compensated disaster. The country or the hospital or our unit can compensate or need the help of the surrounding. About infrastructure, we classify the disaster, which is damage of infrastructure or a simple, if we can't damage the infrastructure, it will be simple disaster. If we have a damage of infrastructure, it's a complex disaster. So we can define the disaster that is natural or not natural, the severity of type 1 or 2 or 3, internal or external disaster, compensated or not compensated, simple or complex. An example, internal or external disaster. If we have a fire in our hospital, this is an internal disaster, and we have to have a plane. We have planned for evacuation plan. This is an internal disaster. External disaster as an accident, an infectious disease, and whatever. This is an external, and it keep into the hospital. Levels of disaster زي ما قلنا ان احنا we can local emergency medical service to deal with the disaster or single area or activated. Level 2 multi-sectorial aid is needed or several local hospital activated. Level 3 state of federal aid is needed or request the aid bases or state or outside the country An example as China or India have external aid when it's level 3 or exceeding the ability of healthcare system while COVID-19 in 2020. So what is the plan of disaster medicine management? Do you guess the plan of disaster management? We have a disaster to deal with. This is a disaster medicine management? No, we have to plan prior to the disaster. Overview our resources. If we have a disaster, what is our resources? If the disaster happens, we have to relieve the activity. Establishment of chains of command and communication prior to the disaster, not on the disaster. Training how to deal with many types of disaster. Community education, and it's important we have to check it, and it exposed during COVID-19. COVID-19 strengthening community education as well, training of healthcare sectors have chains of communication, command and control management, but community education is very important. Avoid inaccessible loss. ليه أنا بعمل البلان أو why I establish a disaster plan? Avoid inaccessible loss, which is the aim of disaster medicine management. Our aim to avoid inaccessible loss, no to have more losses that I can avoid. So the crisis medicine management aims to assure that the foundation manages major crises in responsible and timely manner. I may deal with or manage this major crisis, but it's for the time, wrong time, or better time, or best time, it will be excellent. The time is more important and very, very, very important to manage. If I have a right thing, but in a not right place, wrong place and wrong time, the right thing is not will be effective. Another fact, the president of foundation will designate a crisis management team, which is responsible for major events that not managed have a terminal effect of foundation of and the community. We have a team will be from the president of the foundation. This the first important definition or thing in this presentation is a disaster cycle. And by the end, I will ask you or I recommend for you and the strengths for what is the disaster cycle, as we have a good plan if we have a disaster cycle definition and deal with it. And another important thing I will strengthen for it is a disaster plan components in response phase. This is where all is in response phase, and we don't have the disaster cycle from the beginning. Disaster cycle from the beginning is very important, as we saw this diagram. It is a repeating cycle. We can't say who or which prior to which, as first step is prevention and mitigation, as we see, then preparation, then response, and this step we all work on it, doing it as we have a disaster management. No, we have all in a response phase. Response phase is a reaction of disaster medicine management, then recovery phase. All of us dealing with this step as a reaction of disaster management, not a real disaster management. Let's see everyone we have the ideal dealing with every step of this. Please remember the disaster life cycle is a prevention and mitigation, then preparation, then response, then recovery. If we deal with response without preparation and prevention and mitigation, we have more and more loss. If we deal with response, preparation, mitigation without recovery, we can't have a weakness point that we can strengthen our response in another one. All steps, it's necessary for disaster medicine management, and I have to ensure again, our reference is an Oxford Handbook of Disaster Medicine Management. If you want a PDF or a link for this book after this session, please ask and I will send to you. Let's have everyone and have to the best information in brief for every step of the disaster lifestyle. Mitigation, it's the first step. Mitigation is the first phase of disaster cycle. Mitigation consists of steps taken to minimize the effect of future disasters. We have to hazard analysis with different steps, have one session alone, we will have the hazard analysis to minimize the future disasters. Have an example. The vaccination of COVID-19 now, not to prevent the spreading of the infection, is to minimize number of patients, minimize signs and symptoms, minimize the day of hospitalization, minimize ICU or death from this infection. Prevention may be as vaccination of polio in Egypt. We have no polio in Egypt. Egypt is empty from polio, but we have a vaccine to ensure and continuity to prevent this infection in Egypt. I think I will try to have this point of view. The mitigation phase differs from the planning phase. In mitigation phase, focuses on the medical or humanitarian response to disaster, more than protecting physical structure and economic development. عندنا حاجتين بفكر فيهم, have two different aspects of mitigation: humanization and the disease or the disaster, and economic development. Now we have all vaccine, not for only disease preventing or mitigating, but also economic development. We have a big problem with economy for last 2 or 3 in all the world. Then the effectiveness of mitigation is dependent on accurate assessment of current of disaster, as I said, for a hazard analysis, analysis of emerging threats, new building skyscrapers, new industrial or chemical plants, new rail lines, airports, seaports, highways, as we have tourism buildings, and also the vulnerabilities or potential targets, such as in COVID-19, an example, vulnerabilities or potential targets: non-communicable disease patients, diabetes, hypertension, old ages, renal impairment patients, cancer patients. This is a vulnerabilities for us in COVID-19. For this group, we have a tight or risk for COVID-19 complication, and this mitigation will have an accurate blood pressure and optimum blood sugar, whatever. This is our vulnerability group. As I have our next wave, it will be protected. This is a mitigation aspect. The prevention aspect have a strategic plan standing on regulations as regulations, wearing a mask. When you have a change your mask or off your mask, you will have an financial issues, or you can't entering any place with this regulation. Prediction is very important. Prediction, the second wave, a new variant, a new it will happen. We have a prediction that will useful to next step. Early detection of new variants, new events. It can be happen. And proactivity is the most important in prevention phase. If you have a late decision, if, as we said, it will not a proper time and the proper act. Prevention phase, as example, in expectant events, mass groups, festivals, national or religious feasts. Our plan to activate with expert team on duty, and we have type 1 or 2 or 3 declaring. This is for prevention and mitigation phase. Let's go to the second phase, that's a preparation phase. Preparation phase consists of planning, training, equipment, and material preparation. Planning or preparation, most defined as activities, tasks, program, system development as digitalization or the pathway and work pathway for the any disaster. It's to predict it. Implementing the most important word in preparation, it's a prayer. When we do it inside the disaster to be a reaction of the disaster, it's in a response phase, the third phase, not to the second phase. زي ما قلنا first phase, as we asked, the first phase is prevention mitigation. Second phase, which is we have now, is preparation. Third phase is a response. If we do this in a disaster as a reaction, we now in a response phase. But we have now in the preparation phase, must be implemented prior to an emergency that used to support the prevention and mitigation and response phase. This is the National Fire Protection Association. This is a definition of preparedness. Preparedness is a continuity process. The second word is important. First word important in preparedness is a prayer. Second word and second definition is important. That is, the preparedness is a continuous process that involves integration of all governmental level, private sector, and non-governmental organization, dealing with the vulnerability and required resources. This is a definition with National Incident Management System. Preparedness can be defined as activity measure designed or undertaken to prepare or minimize the effect of the hazard of population created by hazard, to facilitate emergency repair or emergency restoration, vital utilities and facilities. The main activities of preparedness fair revolve around planning, training, and doing the plan. This is a preparation phase. Let's remember the life cycle of disaster to be focused. The level, first step of this disaster is a prevention and mitigation. Today's presentation, we have a principles, that's just a principle, just points. Prevention and mitigation phase that we have discussed. Prevention is to minimize, to prevent the action, and mitigation to minimize the effect of this action. Then we have a preparation. We have the main points of preparation and definitions. Now we have to do. We will all skip the first and second step. Okay, we will have now to move to response phase. Response phase with the phase we all stuck on. When the hospital faced mass casualty situation, every staff member should be informed, trained, know the plan. It's important to be committed and predefined rules. الchaos, it's most mistake we have on disaster. We have running or everyone have a concept for disaster. No, the disaster in manner of the management, we have to, every staff member of the hospital should be pre-informed, trained, knows the plan, and committed for his predefined rule. As we have telling this as an action course, everyone must have the back of his daily action cards that contains name and specialty. In disaster, we have a back of this action card have the rule as I will the trash officer in disaster. I will be the senior of theater room. I will be the senior of emergency room on the back of his ordinary action card. Response phase, and this is the second mission for us today. The first mission, that the disaster I will back against the disaster life cycle. It consists of first step, prevention mitigation, second step, preparation, third step, response that we have, fourth step, recovery. A response phase, the third step have an important point. I will remember at the last of this presentation. What's your name? I have, my name have 4 steps of disaster medicine as a lifestyle. What's your next name? And response phase C, S, C, A, triple T, C, S, C, A, triple T. This is important for us all. Okay, let's go to have this points. The response phase consensus of command and control by order. We can have another one and replacing another one. Command and control. Safety is prior to, we have stacked all in treatment. In disaster, we have stacked on treatment. This is prior the last. No, our safety, it's important. If you don't save, please don't move. Communications, assessment, triage, treatment, transport. Today, we have definitions or short notes for each other, and next, inshallah, next week, inshallah, we will have a triage workshop. Triage workshop is very important, as continuity of training of this triage give you a chance to spot triage on disaster. First one is a command and control. Command and control is very important. If you fail to plan, you will fail. Or if you fail to plan, you plan to fail. This is important issue. Command and control of disaster management consists of crisis management committee and crisis management team. The difference between them we will say later. We can have managerial hierarchies, and we clear, pre-informed and committed. Everyone have a predefined rule. Key areas in our hospital, we will receive patients in in red rooms, or right yellow rooms, or green rooms, predefines the key areas of our hospitals according to our triage. Alarm and activation system, who can say declaring disaster, who will have a decision to have this hospital from an ordinary work to the disaster work, will declaring disaster now. Media management is very important in a command and control. Information, volunteers management, it may have a wrong rule if it are not organized. Evacuation plans, traffic routes of both doctors, healthcare workers, and already victims as well. Crisis management team and committee. What's the difference? Crisis management committee will be responsible for prevention and preparation phase, including planning. Committees such as our federation, or our ministers, or our country have to do rules, have to have some which is in other governmental issues. This is a crisis management committee. It's responsible for prevention and preparation phase only. Then the crisis management team were responsible for a response phase, which is physicians or have an experience in medicine that deal with response phase, from the command and control to the treatment and transport. Then both of teams responsible for recovery phase. Recovery phase, which is have a re-audit and have weakness points, strength points, that have the committee to have a prevent and mitigate with another rules, another actions, another community education, or another community rules, with the team that's responsible for deal with this disaster. Emergency Management Committee motivated multidisciplinary committee from the Minister of Health, the Minister of Education, the Minister of Higher Education, the Minister of Communications, whatever. It's a multidisciplinary committee essential for successful planning. The committee should be regularly and consist of clinical and non-clinical representatives, as deal with the healthcare sector and economy and teaching of the Ministry of Teaching and Emergency Medical Service, Emergency Management, Public Health, the Committee of Clarify and responsible of internal personal networking. The committee should have an activity and include creating updates to all hazards of emergency medicine program, conducting a hazard or vulnerability analysis. As an example, in our vulnerability analysis, as I said before, non-communicable disease patients, old patients, and as well the schools decision will have to teaching in schools or online, whatever, developing emergency operation, that standards operating procedure to address the hazard identified, providing continuity and operation planning by writing needs hospital operation plans, and also have to update according to the hazard. Then the next step after companion control and safety is assessment. Assessment is very important, and we have a photo to assure it and be predefined for you. Methane reports needed for assessment. Assessment is a rapid technique from the site of the disaster. The first resources to arrive on the scene and send off حاجة اسمها methane report. Methane message include METHANE. This is abbreviation of methane report. Methane reports, the first one or the first officer arrived to the site or the scene of the disaster must give a methane report. The methane report will be helpful to have a decision and to transfer this patient or the victims to the proper hospital. If the nearest hospital for me is a pediatric hospital, can I refer to the burn victim? No. So the methane report is very important to have decisions, but it will be transport or informed from the first healthcare officer reach the scene of this disaster. Methane in 4 major incidents. This I have methane message, standby being declared. Yes, I have a major incidence in our message. In our message, if I first healthcare doctor or physician arrive to the scene, I have a message for major incidents. If I said that, we have an attention for another receiving hospital or healthcare keepers. Then I will inform from my message and my exact location. My exact location, what is the exact location or geographical area of the incidents that I can use system will be understood by all responders that I may be a part of this disaster management. Then my message must have a type of incidents. As I said, the type of incidents, as I have an outbreak, flooding, fire, to be prepared for this. Then my message have H4 hazard. What is the hazard of this disaster? Our potential hazard can be identified to be ready. Next, A is for the access. What's the best routes for the access or egress? Has my ambulance or my aid can reach me to have a rapid evacuation and relief for this disaster? N for number of casualty, how many casualties are there and what the condition are they in to be steady and ready for receiving this disaster. And when I have the number of the disaster, I will have another 1 or 2 or 3, how many hospitals will be deal with, and what is the degree of our disaster. Is it exceed our capacity or not? This is important for methane. The last E is emergency service, which and how many emergency response to personnel required to already on the scene. What is the service that they need? Methane report seems to be not important, but it's the most important to have the next step to deal with the disaster. As an example, this photo from the Sohag, I think Sohag train. The first one arrived to the scene, or the ambulance didn't give the routes, so they can't inform the authority to have a bridge here, so they can move and transport patient on these rules. Another example, Ryan on Morocco, it was a single child, but it was a disaster to deal with him, as when we evacuate, it will one, but it is a disaster for Morocco. Let's go to communication. Communication, it will be beneficial. It must be have some points: public information officer, spokesperson, and event coordinator. What's the difference between public information officer? Coordinate communication efforts, act as spokesperson of governmental and health organization. The project on behalf of the organization. So the public information officer, he is speaking on behalf of the organization. The spokesperson acts as the face of the organization. Then the event coordinator schedule and publicizes the press conference, coordinate multiple media interviews, create shift schedule of multiple spokespersons, schedule a tool or damage area for the media. So we can organize the media from 3 steps on our organization. We must have a public information officer, which is a role and job description, spokesperson that acts as the face of organization, and at last the event coordinator. Let's go the next step for our time. I saw that our time is running. Triage. Triage, what is the triage? And triage categories, triage tools. On brief, as we have recognized that the next week we have a triage workshop. We will play for triage. Definition of triage. It's a very important. Triage is a French word, has been defined as doing the greatest good for the greatest number. Greatest good, the key is doing greatest good for the greatest number. The triage is a dynamic process. We have 2 different definitions: military definition and civilian definition. The military definition generated by Napoleon Bonaparte, as we have the triage word is a French word, was Napoleon Bonaparte that have the priority to get as many soldiers back into action as possible. He will triage the most light victims to treat them rapidly and back into action as soon as possible. طيب, civilian definition, the priority to maximize the survival of the greatest number of victims. Do the best greatest number to have greatest number and least number of victims. Aim of triage, doing the right patient in right place in right time, the most important keyword, without regress. Without regress. Triage is a dynamic process. We can do triage first as the scene, at evacuation, in hospital, before surgery, post-operative. We can triage one person as a yellow, not priority for now, not high priority. Then at minutes, we have a dynamic process. The same patient become from yellow to red. And also we have an immediate patient or red patient, which is complicated, have blood transfusion or fluid transfusion to change it to yellow in our triage. So the triage is a dynamic process. We have a continuously do it. The first type of triage is triage by sieve. We have 2 types: triage by sieve, triage by sort. in Arabic terms التصنيف بالغربلة والتصنيف العادي. تصنيف بالغربلة بغربل patients triage by sieve. Okay, the first triage of sieve is performed in the field of implants. A priority of triage sieve is located triage tag each casualty is the first step from our medical treatment is in triage sieve. The goal is spent to 20 seconds, only 20 seconds in every casualty. During triage sieve, it's the most important point. During triage sieve, only immediate life-saving treatment is providing. Even in disaster, we can't do anything medical in triage sieve. Triage generally limited to opening airway, performing an airway maneuver. If we haven't a respiration, we must open airway. The only immediate life-saving treatment on triage sieve. This is a diagram of triage sieve. First, we have say in the scene, if the patient or the victim is walking, please, if you are walking, go this side. If walking, go this side. If the victim or the casualty can walk, it is a green. It is a green or delayed priority. Then, if the patient or casualty or the victim can't walk, we will check for breathing. If he breathes, okay, we will have another triage tools. Or if he don't breathe, if he doesn't breathe, we will open airway. This is the only medical step on triage sieve, opening the airway. If we open the airway and the patient going respiration, okay, it will be immediate or red. If no, the patient is die. Okay, let's go to the next step. If patient can't breathing, then I will open the airway. If his respiration 9 or less, 30 or more, this victim have immediate priority 1 or red. Or patient capillary refill over 2 seconds, also this victim or this casualty immediate priority 1. Okay, if the patient capillary refill below 2 seconds, if respiratory rate from 10 to 29, the patient is urgent is our priority 2. Again, next week, inshallah, we will have a workshop for this triage in details. Walking or not walking. Walking, okay, green. Not walking, I will check for breathing. Opening airway. If the opening airway, you have the breathe, okay, will immediate. Can't breathe, the patient is died. Then the patient opening airway and breathing is immediate. The respiratory rate not between 9 and 30 is immediate, or over 2 seconds is immediate. Another one, capillary refill between below 2 or respiratory rate from 10 to 29 will be yellow or urgent. This is the room or key areas for triaging in thin and in hospital on our plan. Next type or second type of triage is triage by sort. It will be a senior nurse or doctor pre-hospital prior to the entry of the hospital or the gate of hospital. First step, we know all to calculate the glaucoma scale. All my terms is new, but also for pharmacists. This is new managerial level to all nurses, pharmacists, doctors. All healthcare provider can be a specialist of disaster medicine management. So the term of glaucoma scale, we check eye opening, verbal response, and motor response. We have numbers for this score. Then we have to calculate the glaucoma score in another from 13 to 15 have 4, from 9 to 12 have 3, another score. We check the respiratory rate of the patient. From 10 to 29, we have a score of 4, more than 29, 3, and to the end, systolic blood pressure, if more than 90, this is scores also, we will have plus X plus Y plus Z. It will give me another score that if the score 12, this patient is priority 3. If the patient is 11, the priority 2. If below 10, priority 1. If 0, patient is died. Upgraded priority depending on injury and diagnosis and follow-up of this patient. Summary, triage is the first step through medical support, as I told you. This is the first step to opening the airway. Triage is a dynamic. Triage sieve is a primary. Triage sort is secondary. Refine priorities. The triage tags define and show the patient's current priority. Then we have next step after triaging is treatment. Need go back in several steps to have a guidelines or protocols of treatment of this infection outbreaks or type of disease. Then the last phase is a recovery phase. As we remember, first phase is prevention and mitigation. Second phase is preparation. Third phase, response is the consensus of CSA-T. And lastly, we have a treatment as the last slide. Then recovery phase. In order to don't lose with me, recovery phase is important phase, the most important phase. As I have an audit, briefing, decide if another communication to stakeholders likely will change impression of better, as we do with COVID-19. To date, no recognized guideline exists to aid disaster medicine information of a specific recovery plan. In general, recovery includes a process of rebuilding, restoring our social, economic, natural environment. The direct or indirect effect of the disaster with the natural or human or the community is bad. We must relieve or recovery from everyone. Coordination is essential that recovery plans address coordination in the next steps, as the failure to coordinate is match population defined needs, the influx of external aid over risk in secondary to the disaster. This approach to recovery efficiently allow community to define the disaster development efforts. Conclusion, the development and encourage the all collective mental division and more resilient post-disaster community, as we have all post-disaster or post-COVID psychosis, post-COVID depression. This is post-COVID syndrome. We have to encourage the community to be restore or recover. Public health or mental health is the most important point of post-disaster, especially in healthcare providers. خلينا let us to conclusion to the time we lost our time. The most important hospital preparedness is essential component for national preparedness against occurring crisis to have the potential to cause serious harm to the population. Planning is ongoing process, must be prior to the disaster, concentrate on regulation and identification hazards and vulnerabilities. Cycle training is important. The plan must be committed and predefined rules. Last not least, this is a famous slide. Acute distress syndrome or chronic distress syndrome on disaster on recovery phase. Most important to have a psychological impact to healthcare workers. This nurse developed acute stress syndrome on this. This is a real in Egypt, and this is our book photo. I think this is identical for each other. Post-traumatic stress disorder or chronic, we must check our healthcare provider in disaster mentally and socially. I think this is important. Summary and Dr. Ahmed, I think that our time is end. The most important keyword in my presentation today, what is the disaster medicine management cycle, or what's your name? Prevention, preparation, response, and recovery. What's your name again? CSA-TTT. I hope that I will do best for you. Thank you.
Thank you so much, Dr. Riham. We really appreciate. And I liked your summary at the end, the 2P and 2R, and then this abbreviation with TTT. So I will keep in my mind, and I'm sure that you, the audience, please, the abbreviation will be very helpful in understanding. And I liked also the methane report.
Yes.
So I believe it's a very important, the first person who will see and watch and inform. It's very crucial. It will change the directions of the senior management on dealing with the issue from right to left, totally. So I personally learned a lot. And I liked also that you differentiate between the committee and the team. So this is quite important. I believe the committee is before, so just for preparation, and the team who is doing the action, correct?
It is a very good question, as we have a distinct point of view. What is my role in the disaster? So we have a fact: the committee is a prevention and mitigation phase, preparation phase.
Okay.
We have a prevention, preparation, have a strategic planning, training, prevention rules, community education. Then when the disaster happens, the team is dealing with, the team which is doing with our hands. Then both will deal with the recovery phase, sitting on the table, have a brief for this disaster, and audit, changing the plan, have a strengthening point, have a weakness point, have any coordination points is needed, then begin again to the committee to prevent and mitigate according to the recovery phase.
Okay, clear, very clear. Thank you so much. So now the floor is open to the attendees to ask your questions. You have three options. You can ask through Q&A. If you go to the below options, you have QA, you have chat, or you can raise your hand to ask questions. So we'll give you the chance to unmute and ask your questions. I'm sure that this topic could be quite new to some of us. So it's an opportunity to ask that we have Dr. Rihan with us.
I'm sorry that I have this is a topic is new, is heavy. We have to days or months to be fulfill this, but if you interest on it, I'm the lover of disaster medicine management. That is a new concept, and it's very difficult to understand easily.
Yeah, but you explained it, this introduction and these basics very in a very simple way. So really appreciate this. So until we receive some questions, yeah, I see. Yeah, okay. So I can see here what is the difference of triage uh, for disaster or just for emergency. Yeah. So please, Doctora.
Mhm. The emergency disaster, the ordinary daily workers for all hospitals we saw to have one aim: do everything for this patient to this patient.
Okay.
Okay, but okay, our triage on disaster is completely different. I do the greatest things for the all, not for one person. So
Okay.
the difference between them, the senior or the responsible person for declaring the disaster. We can have an example to be clear. On COVID-19, we heard about the war medicine that we choose who of the patient we will deal with. We can have one one ventilator and two patients, or one ICU bed and more patients. On ordinary work, we have the poorest patient to deal with at first. On disaster, we can deal with the worst patient. We will choose the best patient. We will have a feedback, as we will choose the youngest patient. We will have a not vulnerable patient as regard. On our daily work, we have to deal with the worst patient.
Yeah, it's. I believe it's a difficult decision during disasters for
Yes.
the healthcare providers to choose. So they have to choose, which is really very difficult decision. While when you are in emergency or regular, you have one patient and you do the maximum to save. I believe it's a really different feeling and different priorities. Yeah. So yeah.
As we have I will search for it, as we have the term of without regret, as the triage doing the right patient in right place at right time without regress. So healthcare provider check must be checked psychologically after the disaster. All
Wow.
healthcare provider maybe have a depression as they choose one and let one. We all hear about the war triage and war medicine. We choose one and let one to die. When we sleep, I can't have an ICU bed from my home or ventilator to my home. I have a healthcare capacity. When the demand or the casualties exceeds the healthcare capacities, it's have to choose or triage or at first declare a disaster. So we have the right patient, choose the right place and right time, the most important word, without regress.
Okay, that's really important to understand. Okay. Any other questions from the audience or comments? Again, you can raise your hand, you can write to us in the chat, or you can write in Q&A. So, questions? Okay. It seems that Dr. Riham explained it very well. So what we expect, guys, from you next time, that you will actively participate. Dr. Riham is preparing a workshop that will help us to be engaged. So active participation is requested next time from all of you. Okay.
Okay, please, Dr. Ahmed, before we ending, you will send this presentation PDF to all. Please next time prepare the slides of the triage by thief and triage by sword with you, as we will play as patients or as a drill, and we will calculate the patient as a teams, which it will be interactive and more delicious.
Okay, that's very interesting. Thank you. Here there is a question from Dr. Samir. Please, Dr. Samir.
Really, thank you very much, Dr. Riham. I liked your presentation. It's a new topic that needs more frequency to increase the awareness at, different level at the healthcare professions. Here I'm alarming. We have a deficit in the awareness level. On the other hand, at the public level, because when there is a crisis, we have seen how people, they are reacting.
Yes.
And nobody knows that there is what we call it proactive measures. We tend to have usually reactive measures. That's what makes a crisis always happens with high incidence in developing countries rather than developed countries. I like summarizing the concept in many acronyms. I've got plenty of acronyms. The idea of having the cycle, it's wonderful. I stayed with the cycle. You have two halves. Half, I call it the first half is the BBB half, the prevention and the preparation. And the second one, I call it the RR half. That was for the response and recovery. You can also add, I suggest, or align, the CMC and CMT. In another slide, when you speak about the CMC and CMT, then you can put the CMC at the first half, deploying the first half. And the second half, you have the third quarter to be for I think the CMT, and then you invite back again the CMC with the CMT to have the recovery.
Recovery phase.
You spoke very well about the Misan and the triage. It's a full of very beneficial insights and knowledge. What I suggest also in the first time, for many people, they hear about this information. So it needs, to keep hitting this. What I haven't seen yet, I guess I would be able to see it next session, is where are the sustainability plan? The idea is people, they know that they are part of the CMC, and there is what we call it the crisis management process, but we don't use it to have what we call it frequent demo to this process.
You have a drill. We must have a drill every 6 months.
To ensure that people are ready, are well trained at any time, so they can practice it even in a false time. I have seen it. It happens only in the embassies only. The embassies, they call people once upon a time. We need alarming the embassy, and they call us, or they call people to make evacuation within, for instance, 5 minutes. So they start practicing things and get people alert and alarming that it would happen, and when it happens suddenly.
Yes.
So the idea of having the dry demo for all people who already received the training, the idea is not to get certification or to, as you said in your comment, which is it's a new topic. It needs a frequency to sustain it up. And myself, I learned a lot from this. Yeah, I appreciate this information and the way you deliver this information as well.
It's honor, Dr. Samir. Let me say that is the most important issue for, as I said, the plan is predefined, committed, trained. The ideal trained is to have a drill. In Egypt, I have 3 hospitals. Drill, the police hospital in Alexandria, معهد ناصر Institute for Research and Treatment, and Bank Al Ahli hospitals. We have a drill every 6 months, and the false alert. And for sustainability, as you said, for the Egyptians and not Egyptians, the teaching hospital authority in Egypt with the Ministry of Health will, I am the manager of the scientific board. We will have a disaster management diploma that is have a degree of disaster management specialist from the Egyptian medical syndicate for the Egyptian and not Egyptian in few next months, inshallah.
Excellent. Thank you very much once again. Yeah, and you did a great job.
Thank you. The honor.
Thank you.
Thank you, Dr. Samir, for your valuable comments. Really appreciate. And probably if someone from the attendees would like to share the experience of your hostel or institute, do you have such drill, such training or something similar? If you have any comment, please you can share with us. That would be very interesting.
And if you please, next one, please prepare for the triage slides to calculate rapidly our game. It will be amazing and delicious for all.
Okay, so we will distribute them so to ensure that next time already the audience have the slides. Thank you, Dr. Alia.
Thank you.
Okay, so far I don't see any questions or comments. So I believe we can close the meeting today. Dr. Mustafa, if you have any comments before we close.
Just one comment. Thank you very much, Dr. Riham Ghallab. Thanks for the very informative and new session. We learned a lot today, and I hope also that all participants, they have the same perception and mindset. Maybe I understand that the level of questions is not so high because of the topic is new. I expect the next time that we will have a lot of questions, more questions, and preparations as well. Anyway, definitely I will be waiting for the next week, and also for the all participants. I think that it will be at the same time on Wednesday, next Wednesday. Let's continue this subject, and thank you very much again. Thank you, Dr. Samir, for your interaction. After finishing the second session, we will share the materials, we will share the presentation, and even the link if someone want to go back for the recorded session. So I think this will be really great. Thank you again, Dr. Riham. Thanks a lot.
Thank you all. Thank you, Dr. Ahmed. Thank you, Dr. Mustafa. Thank you, Dr. Samir. Thank you for all participants. And I hope we have an information clear with you.
Thank you.
Thanks again. Thank you to everyone. We really appreciate your presence and have a good evening. Take care.
Thank you. Good evening.
Thank you.
Bye-bye.
Thank you.